Another video reviewing ICLs to help educate patients and students and doctors who are interested in this procedure.
So here's the beginning of ICL, Implantable Collamer Lens surgery. This is a lens that needs to be placed inside of the eye, which is why we see a few incisions being made in the cornea.
And then numbing plus viscoelastic is placed to dilate and maintain space. A larger opening is created so that the lens can be implanted, and the scoring is so that you have a nice edge, plus blood vessels help heal.
How large is that incision going to be to get the ICL in?
So it's 2.7, 5 is that blade, and then you saw I went a little bit sideways to make sure that this lens, ideally 3, fits in easily. I like that I cannot quite insert the tip of the inserter so that there's less risk of injury to the natural lens.
This is the loading of the ICL, getting prepared before to be placed inside of the actual eye.
And the lens vaults upwards, and as you can see, the difficulty is getting the 2 edges underneath the ledges so that when it closes, it vaults upwards. That way it unfolds correctly, and I know which side is up by a little dot that's in the right leading edge and the left trailing edge.
And it ends up being kind of 4 legs or 4 edges of that ICL that are going to be placed behind. This whole lens is destined to be behind the iris. So here it is going into the cornea, being placed in the anterior chamber.
The lens now is in a soft eye. You see the little wave that's viscoelastic, and then the lens goes in. I retract so that the trailing haptics don't get smushed by the injector or trapped. And then once it goes in, you see it already unfolds, and it's unfolding in the correct way. And I did that by checking the right leading and the left trailing haptic. They should have a little dot.
So these patients are generally young. They're phakic. They have their natural crystalline lens. They don't have a cataract. Of course, there's great care is taken to place this lens in very delicately, so it's not actually rubbing or bumping against the actual lens.
Correct. So this is placed in the periphery underneath the iris. Those little haptics or plates keep the lens in place in the sulcus, and to make sure that it unfolds correctly, I kind of sweep on top as well to keep the iris away so that the lens doesn't stick up into it.
When you use the word sulcus, we're talking about the area just behind the iris. You almost have to imagine where it is, that ring around, right where you see the white part of the eye meeting the iris. The sulcus is that area right behind it. That's where that ICL is going to be snug for the rest of that patient's life or until cataract surgery.
And the lens itself kind of bows backward in that area, so that's why the ICL is also bowed similarly. It vaults over the lens in the center and then kind of follows that curvature in the periphery.
In that view, I can actually see some of those little holes in the ICL there. That's going to allow passage of fluid from behind to in front of that lens.
Otherwise, the lens would block the normal circulation of fluid from the back of the sulcus into the front part, into the angle, and those ports allow fluid to circulate normally. This is now irrigating out the viscoelastic that, if left inside the eye, would also cause an increase in pressure and cause the vault to be incorrect. So you can see kind of fluid waves slowly washing out that viscoelastic. Their recommendation is at least 10 cc, 10 milliliters of fluid, or at least 1 minute of irrigation.
Patients who are eligible for this surgery could include, for now, myopes with some levels of astigmatism also can be corrected. Currently in the U.S., not hyperopic prescriptions.
Correct. 4 diopters of cylinder, up to 16 diopters, and even if somebody's higher, you can combine this with LASIK to decrease the amount needed to be corrected with LASIK. So let's say somebody's minus 18, good do an ICL, and then on top correct the rest on the cornea.
What would you suspect would be the maximum amount that LASIK could correct? Why would somebody choose ICL instead of just doing LASIK? Because of that high refractive error?
Absolutely. The more tissue removed from the cornea, the less remain stable, and there's a certain amount that you can remove safely. If it's higher than that, ICL is a great option.